intrinsic conduction system of the heart. You should be able to follow along with the cardiac physiology PowerPoint starting on page 7. As we've mentioned previously, there are two major cell types which make up the heart. Cardiac muscle cells make up about 99% of the heart, and autorhythmic cells make up about 1%. Remember that autorhythmic cells spontaneously depolarize, producing action potentials over and over again. These autorhythmic cells make up what's called the intrinsic conduction system of the heart. The role of the intrinsic conduction system of the heart is to initiate and distribute action potentials so the heart depolarizes and contracts in an orderly manner, with atria contracting first and ventricles next, then atria, then ventricles. Remember that autorhythmic cells are found in 5 locations in the heart. The first place they're found is the SA node, which stands for sinoatrial node. And you'll notice that this is found in the right atria only. Next, the action potential travels through the internodal pathway to the AV node. AV stands for atrioventricular node. And you'll notice that this is also in the right atrium. Now you'll also notice that the SA node is going to pass on depolarization to the left atrium, and that's what these arrows are here. And these are passing, this is ions basically being passed through gap junctions until the cells of the left atrium depolarize. And they pass so quickly that essentially the right and the left atria depolarize at the same rate from the top down. When the action potential gets to the AV node, there's a slight delay before it passes on to the bundle of His. The bundle of His is named after Dr. Wilhelm His, who discovered it in the 1870s. It is also called the AV bundle. From there, it passes to the right and left bundle branches, and then up through the Purkinje fibers to the rest of the heart. Now, as I mentioned, there's a slight delay for the action potential passing from the AV node to the bundle of His. And the reason there's a delay is because the fibers, the autorhythmic fibers that exist between the AV node, narrow down significantly on their way to the bundle of His. It's kind of like traveling from a 4-lane highway to a 2-lane highway. So this causes a slight delay of about 0.1 seconds in the movement of depolarization through the heart. This also allows the atria to complete their depolarization and contraction before the ventricles do. Another thing that you might notice is that these muscles here, you might remember this, these are called the papillary muscles. And remember that they are attached via the chordae tendineae to the tricuspid and bicuspid valves. These muscles contract a split second before the ventricles contract, so that they can pull the valve closed before the ventricle contracts, because you want the blood to go up through the pulmonary trunk if you're in the right ventricle, or the aorta if you're in the left, but not to backflow into the atria. So these have to contract a split second before the entire ventricle contracts. And the way that happens is you can see that the signal passes up through the papillary muscles before the entire ventricle depolarizes. The ventricle depolarizes from the bottom up, as opposed to the atria, which depolarize from the top down. In addition, during the dissection, you might remember something called the moderator band. The moderator band is a tiny strap of muscle that connects the papillary muscles to the interventricular septum. Remember that the septum is insulated so that the action potential can't leak out into the ventricles. It has to go all the way to the bottom. But the moderator band allows the action potential to take a shortcut to the papillary muscles so that they can contract earlier before the rest of the ventricle. The time it takes for the action potential to travel from the SA node all the way through up until the last ventricular cell is about 0.22 seconds. Now, if we look at the autorhythmic cells, each of these nodes or clusters of cells depolarize at a different rate. The SA node depolarizes about 75 times a minute, which means that if it was in charge, your heart would contract about 75 times a minute. Your heartbeat would be about 75 times a minute. AV node produces action potentials about 50 times a minute. Bundle of His about 30 times a minute. Bundle branches 30 times, and Purkinje fibers 30 times. So which of these autorhythmic cells sets the pace at which the heart depolarizes and contracts? Which of them? Well, as it turns out, it's the fastest, and that would be the SA node. So the SA node actually sets the rate at which your heart contracts, and for this reason they call the SA node the pacemaker cells, or the pacemaker of your heart. When the rhythm of your heart is based on the SA node, they say that you are in normal sinus rhythm. If something should happen to the SA node and it's damaged, the next fastest node takes over, and in this case it would be the AV node. If the AV node is setting the pace at which your heart contracts, they say that you are in junctional rhythm. Now your heart is contracting about 50 times a minute, which is still usually sufficient to get enough blood to all the tissues. But if both the SA and the AV node get knocked out, then either the bundle branches, the bundle of His, or the Purkinje fiber will take over. And 30 beats a minute is really not sufficient to keep your heart and your tissues functioning. Even though we said that the heart creates its own action potential through the autorhythmic cell, and it does not need the nervous system in order to initiate contraction, your heart still is modified by the nervous system. So that means that the rate at which your heart beats is modified by the nervous system. And it's actually by the division called the autonomic nervous system. You might remember this is the involuntary branch of the nervous system, and it regulates things like smooth muscle, cardiac muscle, and glands. So the autonomic nervous system can override the intrinsic conduction system in certain situations. So let's take a look at how that might work. So think of your heart as innervated by both divisions of the autonomic nervous system. So one division is called the sympathetic division and the other is the parasympathetic. You might remember that the sympathetic is called the fight or flight division, and this is because it is activated usually in emergency situations. So some people call it the E division because it kicks in when things with the letter E occur, such as emergencies, excitement, embarrassment, Now, the sympathetic nervous system travels to the heart through cardiac sympathetic fibers, and it innervates the SA node, the AV node, and heart muscle. which means cardiac muscle cells. So that's where the sympathetic fibers go. The effects on your heart rate, if you think about the fight or flight response, is to increase your heart rate. So remember we said that the SA node sets the rate of the heart at about 75 beats a minute. Well, if you were going to exercise, that wouldn't be sufficient to get the blood to your skeletal muscle tissues quickly enough. So the sympathetic nervous system would increase your heart rate, maybe to 150 or 180 beats a minute. It also would increase the contractility of the heart muscle. And contractility means the force with which the heart contracts. So this is the effect of the sympathetic nervous system on your heart. By the way it increases the force or the contractility is by increasing the entry of calcium into the muscle cell, which you remember will prolong the action potential, will prolong the plateau of the action potential. The other division of the autonomic nervous system that also innervates your heart is called the parasympathetic division. This is called the resting and the digesting system, and you might remember that people nickname it the D division because it kicks in when things with the letter D occur, such as digestion, defecation, and diuresis. The parasympathetic nervous system travels to the heart through the vagus nerve, and it innervates the SA node and the AV nodes. Its effect on your heart rate is to decrease your heart rate. So if we think about it, when you're at rest, most people's heart rate is anywhere from 70 to 80 beats a minute, or maybe even lower, maybe 60. And we said the SA node sets the rate of the depolarization and action potentials in the heart to about 75 times a minute. But this isn't actually true. The SA node actually sets the rate at about 100 times per minute. So that means it causes the heart to depolarize and contract about 100 times a minute. However, when you're at rest, your heart rate is around 75 beats per minute. So that means when you're at rest, the parasympathetic nervous system must be dominating, must be modifying the heart rate and slowing it down. On the other hand, again, when you exercise, the sympathetic is going to dominate to increase your heart rate above the rate that the SA node would set it. If you were to cut the vagus nerve to the heart would continue pumping for a while, and it would probably go up to about 100 beats a minute because there would be no more vagus nerve innervation of the heart. So there is a way to actually measure the electrical activity occurring in the heart, and that's something called an electrocardiogram, which is a graph of the electrical activity occurring in the heart as measured at the body surface. So again, this is a graph of the electrical activity occurring in the heart as measured at the body surface. An electrocardiogram is often abbreviated EKG, or some people abbreviate ECG. The reason it's abbreviated EKG is because the Germans actually invented the electrocardiogram, and they began cardio with the letter K. So I will be using EKG, but ECG is also synonymous. Now, when I say that it's a graph of the electrical activity occurring in the heart, what I really mean is that it represents all the action potentials generated by cardiac muscle cells. So So again, it really, an EKG, represents all the action potentials generated by cardiac muscle cells. And this can be measured at the heart surface fairly easily. When you take an EKG, usually there are about 11 leads attached to different parts of the body. So inside, on the medial side of the forearm, right about where the elbow is, medial side of the wrist, usually the legs, and different parts along the chest and trunk. And you end up with these three characteristic waves. The first wave is called the P wave, and this represents all the action potentials that occur as the atria depolarize. The P wave has an average time of about 0.8 seconds. So give or take, it's around 0.8 seconds. The next thing that happens is after the atria completely depolarizes, the atria contract. And since this is a measure of the electrical recording going on in the heart, there is no measure of contraction because that's really force. You can see that this x-axis is actually time in seconds, and this y-axis is a measure of the membrane potential in millivolts. So it is not measuring force, which is why nothing shows up at the end of the P wave. You can't see contraction on this graph. The next characteristic wave is the QRS wave. And this is a measure of the ventricles depolarizing. So you can see it's written right over here. It's a measure of all the action potentials occurring as the ventricles depolarize. And this has a characteristic time, too, of about 0.8 seconds. Next, you have, right after all of the cells depolarize and you produce an action potential, there should be a contraction of the ventricles. But of course, you can't see it on this graph because the graph does not measure force. And lastly, the third wave is the T wave. The T wave measures all the action potentials as the ventricles repolarize. And the time for the T wave is about 0.16 seconds. So this is pretty characteristic. In addition, there are intervals and there are segments that can be measured. And the segments and the intervals give you additional information about what's going on with the heart. So again, you have the P wave, which is showing you all of the action potentials occurring as the atria depolarize. Then the atria contract, although you can't see it here. Then you have the ventricles depolarize as represented by the QRS wave. And finally, the ventricles repolarize as represented by the T wave. And this just keeps going on and on. Now, one thing that you might notice is missing is there's no repolarization bump for the atria because they should repolarize. There actually is one, but it's hidden in the QRS, under the QRS wave. So there would be a little bump there. So the next question is, why do physicians and nurse practitioners ask for EKGs? What can they tell you about the heart? Well, they actually can help evaluate the condition of the heart. For example, if you've had a heart attack, it can show you what part of the heart is damaged. It can also show irregular heartbeats, or if a part of the heart has a decreased oxygen supply. If the PR interval here is too long, it indicates there's damage to the AV node. In addition, if the T wave is too flat, it might indicate coronary ischemia, which means lack of oxygen to the cardiac muscle. If you have an enlarged QRS, it might mean if you have a large QRS, it might mean you have an enlarged heart, which isn't necessarily good. Sometimes the QT wave the Q2 interval can be too long, which can be because of myocardial damage or electrolyte disturbance. So there's a lot of things that you can read or information you can get from an EKG, and it's pretty cheap, and it's quick, and it's non-invasive. In this picture, it kind of matches the EKG with the electrical events going on in the heart. So you'll notice here that when the P wave shows up on the EKG, the atria have just begun to depolarize. When you get to this little segment, at the end of the P wave, the atria have completely depolarized. The next thing they're going to do is contract, but of course that doesn't show up on the EKG. When the QRS wave shows up, the action potential has passed through the bundle branches and is starting up through the bottom of the ventricles. When all of the cells in the ventricles have depolarized, you're on this little section here between the QRS and the T. When the ventricles begin to repolarize, as shown in red, the entire T wave is on the EKG. And when all of the ventricular cells have repolarized, you have this little end to the T wave. Now, EKGs are fairly complicated. There's a tremendous amount of information you can get from them. But I thought I would just mention one imbalance that can be picked up by an EKG, and it's called a heart block. A heart block is when there's interference of the movement of the action potential from the atria to the ventricles. Okay, so that's what a heart block is. If you look at the EKG here, the normal EKG, you can see the P wave, the QRS, and the T. The P, the QRS, and the T. And it just keeps going on and on. Remember that the x-axis is time in seconds, and the y-axis is the membrane potential in millivolts. So the time for each of these waves and segments can be measured by counting the number of blocks on the bottom. If you had to, one of the 5 little squares here is equal to 1 second. So 5 little squares. On the other hand, 10 squares here is equal to 1 millivolt. So let's look at a first-degree heart block, which is shown down below. A first-degree heart block is when there is a delay in the movement of the action potential from the atria to the ventricles. So in this case, there is a delay of the action potential moving from the atria to the ventricles. If you look at the EKG, you can see the P, QRS, T, P, QRS, T, P, QRS, T. So the distance between the P and the beginning of the Q is longer. And there is a rule of thumb that if the PR interval is greater than 0.25 seconds, you have first-degree heart block. So what do? Well, they often don't do a whole lot about this. There usually aren't any symptoms, and usually there's no treatment. Second-degree heart block, which is over here, is when not all of the action potentials make it from the atria to the ventricles. So not all the action potentials make it. If we look at the EKG here, you can see a P, QRS, T. P, oops, no QRS, no T. P, QRS, T. P, oops, no QRS, T. So what's happening is because every other action potential is not making it, there's no QRS and there's no T. If the action potential doesn't make it to the ventricle, it doesn't depolarize, so there's no QRS as in here, and it doesn't repolarize, so there's no T. And that's what's going on in second-degree heart block. This is a little bit more serious, and depending on which type of heart block you have, they could use medication or other things to control it. In third degree heart block, which is shown above, no action potentials are making it from the atria to the ventricles. So no action potentials make it. And if you look at the EKG, you can see there's a P. This is a QRS, this is a T. Then there's nothing, then QRS-T. And so what's going on here is that there's no relationship between the action potential in the atria and the ventricles. What happens is that the SA node and the AV node depolarize and you get a P wave. But then the action potential never gets to the ventricle. But you remember that the ventricle has its own autorhythmic cells that depolarize about 30 times per minute. So they produce their own action potential, but it's not in sync with the atria at all. And this is quite serious, usually resulting in death. This is called ventricular fibrillation, and in this case, it is out-of-phase contractions between the ventricles and the atria. So this is a little worse than third-degree heart block, and certainly third-degree heart block will lead to ventricular fibrillation if you don't get to the hospital quickly. Some physicians have described this as a squirming bag of worms, because if you were looking at the heart, if it was opened up and you were looking at it, the pericardium that's covering the heart would look like there were points pushing up from inside. And they think it looks like there's worms inside that are pushing up on the heart and poking at it. And it's not really that. It's actually the myocardium contracting completely out of phase. At this point, the heart is pretty useless as a pump because the ventricles are not pumping out the blood as it moves through the heart. And unless something is done, the person will die. Usually what they do is apply shock. They run an electrical current through the heart by applying shocking pads, and that stops the heart, in which case you get a straight line. And then what they're waiting for is the SA node to take over and start the basic rhythm of the heart up again.